Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about some of the decisions patients are faced with in the treatment of breast cancer with Dr. Sarah Schellhorn. Dr. Schellhorn is an associate professor of medicine and medical oncology at the Yale School of Medicine. Here's Dr. Weiner.
I know that over the course of the past decade plus, you have taken care of countless women with breast cancer. And some of those are young women. As people know, breast cancer affects women of all ages. It becomes more common as women grow older, but it is a cancer that's pretty common in younger women too. And so issues about fertility come up.
They sure do.
Maybe you could just, start with a few thoughts about how you approach those conversations with patients.
So it's always a challenge when you're meeting a patient for the first time and they've been given this new diagnosis of breast cancer, and there are lots of things that have to be talked about regarding the new cancer, regarding the treatment, regarding all the options. You've got surgical options and medication options and radiation options, and it can all be overwhelming. But it's really important to remember that young women in particular may not have completed their families. They may not have had children or as many children as they would want. They may have plans and they may have been putting things off for career or other reasons. And those are critical lifestyle pieces that we have to consider in the treatment of breast cancer. So kind of when I see a new patient, that I have a little bit of a mental checklist that I go through that's certainly talk about the cancer, talk about the reasons for various treatments and the reasons why things are being recommended. But we also want to make sure that we're taking into account, is your family complete? Have you ever thought about having children? Because a lot of the treatments that we use in the treatment of breast cancer can affect someone's future fertility. They may prevent someone from being able to carry a healthy pregnancy if they were to become pregnant while on these medications. So these are critical conversations that have to happen.
Yeah. And they affect fertility in different ways. So yes. Chemotherapy, for example. Chemotherapy, as I think many of our listeners know, can put a woman into menopause.
Yes.
But that's not always the case, and it's very much age-related.
Yes.
Talk about that a little bit. I mean, if you're a 25-year-old, are you going to go into menopause with chemotherapy?
You may go into a temporary menopause, and you may have hot flashes and be kind of uncomfortable from a menopausal standpoint for a short period of time. But in all likelihood, a 25-year-old has very robust ovaries that are going to kick it back into gear within a few months from completing chemotherapy. The older a woman is and the closer to natural menopause, the less likely that they will regain fertility. But a 25-year-old, a 30-year-old, very likely to be able to will have menstrual cycles again, may be able to become pregnant. And there are even things that we can do during chemotherapy that can help preserve fertility.
And what are those things?
I feel like you might know the answer to this question, but
it's okay.
We can actually use medications called GnRH agonists. They're shots, injections that effectively put the ovaries to sleep, kind of put them into a dormant status so that the chemotherapy doesn't affect them as much. And studies have shown that women who receive these additional treatments during chemotherapy are more likely to go on and carry healthy pregnancies in the future. So we use those a lot in people who desire future fertility. That's one option during chemotherapy itself. But you also have to remember when someone is undergoing chemotherapy and their ovaries are a certain age, whatever that woman's age is, those ovaries are not getting any younger, and any eggs that are contained in those ovaries aren't getting any younger. And so even when we try to preserve someone's fertility by using these injections, we still may advise them to preserve eggs or embryos if they're in a committed relationship, to enhance the options of having a healthy baby, healthy pregnancy on down the line. Because the older an ovary gets, the older the egg gets, the more chances that genetically a baby may have more problems.
Yeah, well, in my former institution, before I came to Yale a few years ago, we had started a program for young women with breast cancer. Something that we're actually starting at Smilo for not just young women with breast cancer, but young people with cancer in general. But the reason I bring this up is that initially we set the cut point for age at 42. It eventually snuck up a little bit as the person who was directing that program also got a little older. But the reason we picked 42 is that's probably an age where there aren't a lot of people who are still thinking about becoming pregnant after that age. And while there may be a few, unfortunately, our options are much more limited. But the other complicating feature is that we also sometimes suppress the function of ovaries as part of treatment for breast cancer.
Yes, or we use medications that are contraindicated. They can't be given during pregnancy because they cause fetal abnormalities. And these are the hormone-based treatments, or probably more appropriately, anti-estrogens. So depending on whatever clinical circumstance, we might put someone into menopause, in which case they can't become pregnant naturally. If they're in menopause, their ovaries are not functioning. Or we use a drug called tamoxifen, which cannot be given during pregnancy. And these are given for a long time. They're given for at least 5 years in many cases, assuming they're well tolerated. And that's 5 years of time where ovaries are also getting older and eggs that are in the ovaries are getting older. So it may become, just because of the normal natural history of a woman's fertility, it may be harder to become pregnant after 5 years of endocrine therapy. So I'm not sure if this is where you were pointing our conversation, but there's a study called the Positive Study, designed, I think, primarily by people at your former institution, that looked at discontinuing endocrine therapy, tamoxifen or other, earlier than the 5 years. So women had to be on that medication for at least 18 months, but could be longer. And the medication was discontinued in an effort to have them achieve a normal pregnancy, either through natural means or through additional fertility treatments. And so far, the results from that study have been incredibly positive, incredibly optimistic that women can stop endocrine therapy, have a pregnancy, deliver a baby, even breastfeed for a little bit, and then go back on endocrine therapy with no detrimental effects to their ultimate outcome, although we're still waiting for long-term follow-up of this study.
And of course, we couldn't do the ultimate study, which would be to randomize patients, because it's pretty hard to randomize someone to get pregnant or you don't get pregnant.
Or not get pregnant. That's a tough study
that's not one that can be done. What was interesting about the results from the study, too, is that about 3/4 of the women, if I remember correctly, actually were able to become pregnant,
right,
and deliver a child, which is a remarkably high percentage.
It is. And especially given that a fair number of those women got chemotherapy. So really reassuring. And I think opens a lot of doors that we previously would have considered closed for younger women with breast cancer.
It does seem that as complicated as this dance is around breast cancer treatment and pregnancy, that there's often a way to navigate a result that is going to both be optimal in terms of treating the cancer and will also give somebody the chance to have a child if that's what they really want to do.
Yeah. It's a careful conversation. It's a long conversation. It can be a really emotional and intense conversation because pretty far-reaching ramifications for a woman's future. But we are often able to navigate chemotherapy, fertility treatments prior to chemotherapy, and even when someone needs to be on endocrine therapy long-term, how we getting a woman to a point where she can try to naturally have a child or with some medical help, have a child.
Yeah. And just, for our listeners, it is worth pointing out that years ago, meaning 20, 30 years ago, it was widely assumed that getting pregnant after breast cancer was something that you always wanted to avoid because the pregnancy could stimulate a recurrence. And that really doesn't seem to be the case. I mean, the data we have, it has never really been shown. In fact, it hasn't been shown.
That's right.
So I think we're in a much better place. We also now can not only preserve embryos, but if someone doesn't have a partner, we can save eggs
or pieces of ovarian tissue, all kinds of different things that fertility specialists have at their fingertips to be able to help. Again, nothing's 100%, but lots of options that can be explored.
And I think this is another example of the fact that you often need doctors and nurses and others from many different fields to provide optimal care. Right. And, as medical oncologists, we're not the ones prescribing fertility treatments.
That's right.
And we need to work with our colleagues in OBGYN.
Yeah, no, the treatment of breast cancer, the treatment of any cancer, it requires a lot of hands on deck and close connections with lots of different disciplines and fields to be able to provide truly comprehensive whole patient care.
Yeah. I just want to come back in our last few seconds before the break and just touch very briefly on the fact that we all recognize this is an emotionally charged experience. I mean, having cancer is hard enough. Having cancer and worrying about wanting to become pregnant or maybe even being pregnant at the time just makes it that much harder.
Absolutely. It's hard enough to have these conversations about treatment, and you throw fertility and families into it. It is that much harder.
Well, we're going to take just a very brief break, and I'll return in just a minute with Dr. Sarah Schellhorn, Associate Professor at Yale School of Medicine, and we'll continue our conversation about other issues related to breast cancer.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where the lung cancer screening program provides screening to those at risk for lung cancer and individualized state-of-the-art evaluation of lung nodules. To learn more, visit smilowcancerhospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. But when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner from the Yale Cancer Center here with Yale Cancer Answers. And I'm joined tonight by Dr. Sarah Schellhorn, Associate Professor of Medicine and a breast cancer expert. We spent the last 15 minutes or so talking about pregnancy and breast cancer. We're going to move on and talk about other hormonal aspects of breast cancer, or in particular, hormonal or anti-hormonal treatments. These are given to a large number of women with breast cancer because somewhere in the range of in excess of 75% of all breast cancers are sensitive to female reproductive hormones. So, Sarah, maybe you could just talk about generally the benefits of these anti-hormonal treatments and perhaps describe the two most common ones that we use to help prevent recurrences.
Sure. So it's really interesting. I think there's a kind of interesting historical piece to the treatment of breast cancer. If you think back, and I can't give you an exact date, but many decades ago, the treatment of breast cancer was pretty morbid, lots of big surgeries. There were some studies of chemotherapy, but what was discovered was in many women with breast cancer, taking out their ovaries and putting them into menopause seemed to be a pretty good treatment for breast cancer. And it was on that further studies showed that many breast cancers, as you said, probably more than 3/4 of all breast cancers express the estrogen receptor or the progesterone receptor. And these are hormone receptors that require kind of seeing the hormone estrogen or progesterone that leads to cells, cancer cells in particular, getting the signals they need to grow and divide. And so these cancers are, in essence, fueled by hormones. And a number of different types of drugs have been developed that work on that interaction between the hormone and its receptor. The oldest is a drug called tamoxifen, which is a competitive antagonist in the breast of estrogen. All that means is if we think about a receptor kind of like a baseball glove, and we think about the hormone like a baseball, and the glove catches the baseball, tamoxifen is kind of like a grapefruit. And if you're running around in the outfield of a baseball field, holding a grapefruit in your baseball glove, you're never going to be able to catch a baseball. It's kind of how I describe it to patients. But tamoxifen blocks that estrogen receptor.
I think it's a great way of describing it. And it actually even works without seeing your hands.
I've got some really great hand gestures going on right now. It then leads into big conversations about baseball teams and, Yankees and Red Sox, but I won't go there. But tamoxifen, when it's given for 5 years, maybe longer, has been shown to reduce the chances of a breast cancer coming back by about half, by a relative risk reduction of 50%.
And if we can just say for a minute what that means in
real people
terms.
speak.
So if you have a 10% chance of having a recurrence, it goes down to about 5.
Right.
If you have a 25% chance of having a recurrence of your cancer, because it's a higher risk cancer, it would go down to 12.5%.
Right.
It's pretty powerful treatments.
It arguably the first real personalized targeted therapy in cancer. So tamoxifen's been around for years and years and years. And
it's got sort of a bad rap.
It does.
Why is that?
Well, I think with the advent of social media and online and web-based chat groups, there's a lot of information sharing. And tamoxifen does have some potential side effects. It can cause hot flashes. It can cause mood changes. It can cause fluid retention and weight gain and people to not feel terribly normal. It can cause headaches. Lots of things that are maybe not horrible from a medical standpoint, but from a lifestyle, quality of life standpoint, can be really problematic. But many women tolerate the pill just fine. And when we think about who are the loudest people on these web-based chat groups, often it's the people who are having the problems that appropriately are asking for help and asking for advice. And the people who are doing just fine are living their lives and not.
And it does tend to be a little bit more problematic in younger women than older women. So you put a 35-year-old woman on tamoxifen, and at least in my practice, I tend to expect a few more symptoms than I would in somebody 20 years older.
And I think it's important to remember that estrogen and progesterone really do serve a purpose in women. And messing around, manipulating hormones can cause problems and big ones that really that impact somebody's day to day. Hot flashes, if they happen only once every few days, probably not that big a deal. But hot flashes that are happening 10 times a night and preventing somebody from sleeping leads to chronic fatigue and mental fogginess. And that's really a big deal. And so a lot of the conversations that we have in clinic relate to that absolute benefit conversation and the relative benefit. So yes, while tamoxifen reduces the chances of a cancer recurring by 50%, if someone's risk of a cancer recurring is really small, the benefit of tamoxifen is also really small. And for many women, it may not be enough to warrant staying on a medication that makes them miserable.
No, absolutely. And what there are alternatives to tamoxifen as well.
Sure. So there's another class of medicines called aromatase inhibitors. Going back to my baseball analogy, aromatase inhibitors basically remove all the baseballs. So you can't catch a baseball if there are no baseballs to be caught. It basically prevents a woman from being able to make estrogen. It has to be given in conjunction with other medicines in very young women who have ovarian function. So that gets a little bit more complicated, but these medicines reduce estrogen levels from a low level to a very low level, almost undetectable level. And the side of
I was just going to jump in and say, you use the baseball metaphor.
Yes.
I typically describe giving one of these medicines along with suppressing ovarian function, which is what we have to do when we do it in a young woman, as entering menopause by jumping off the high dive instead of wading into the water.
It's not a slow process. It's not a natural process. That's not what normally happens. It can be. So the side effects of those aromatase inhibitors is just kind of like menopause, only more so. And you think about putting somebody who has normal ovaries, whose normal ovarian function has fluctuating levels of hormones and has normal menstrual cycles into menopause is like jumping in from the high dive or going from 60 miles an hour down to zero. It can be very jarring.
And what's funny is for some people, it's associated with almost no symptoms. And for other people, and I don't know how to predict this, it's just miserable.
I hope someday we get to a point where we're able to predict how someone is going to feel. And I don't know what we'll use to predict that. Maybe there will be some smart genome technology. Maybe there will be some prior menstrual history piece to all of this. But that's a hard conversation to have. The only way to know if someone's going to have side effects is for them to try it and see what happens.
And I think the point you made that, we give these medicines for a long time. So these are symptoms that may not be life-threatening, but they're pretty annoying. And so putting up with them for a number of years for many women is often challenging, to say the least. Now, on the other hand, these hormonal, anti-hormonal, endocrine therapies, they're called all of these different things, sometimes are far more beneficial than treatments like chemotherapy, and it all depends on the tumor.
That's exactly right. Breast cancer isn't one disease, and it's this big spectrum of diseases, each of which is treated a little bit differently, or even a lot bit differently. We make decisions based on a few things that the pathologist tells us when they look at the cancer under the microscope. We look at the grade of the cancer. That's a measure of how aggressive the cells look under the microscope. We look at the percent of cells that have the estrogen receptor or the progesterone receptor. And then there's, this may be where you were going with this question, but there's this test called the Oncotype test, which is a test of a patient's individual cancer. It looks at 21 cancer-related genes, and it looks at the levels of those genes and what levels they're expressed at. And based on the levels of those genes, it goes into this very complicated algorithm that some very smart people developed many years ago. And then it spits out a number. And so you often, in breast cancer circles, you may have people saying, well, what was your number? What was your number? The recurrence score is a number, and it's on a scale of 0 to 100. Most breast cancers have low numbers under 50. And then depending on that recurrence score, we can decide whether somebody needs chemotherapy or benefits from chemotherapy or really doesn't benefit from chemotherapy. And a couple of major studies that have been published in the last 5-7 years have shown that Oncotype recurrence scores of 25 or lower are not associated with much benefit to chemotherapy. There's some caveats to that. There's some questions in young women in particular, but in most women, low oncotypes then don't benefit much from chemotherapy, if at all.
And it's so different from the way it was 30 years ago, where in fact it was one size fits all.
Right.
And, we didn't differentiate between different cancers. We gave everybody essentially the same treatment, and it's come so very far. And at the same time, not only are we able to allow people to live with fewer side effects, but we're certainly doing no worse in terms of overall outcomes. And I think, just as a sort of give people a general sense, what proportion of women who have breast cancer go on and live a normal life afterwards?
A large proportion, 85% go on and are never hear back from this cancer, from their original cancer. And even women who do hear back from the cancer, whose cancer comes back, whether in the breast or somewhere else, go on to live many, many years because of the advances in treatment.
Dr. Sarah Schellhorn is an associate professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.